Alexander already explained a little bit that maybe logically I should have started with a part that is more was done for you, more meaning for your needs as sales representatives. But we decided to invert, and we start with the lecture that is just the lecture that I would have done for the expos. And this maybe makes a bit less sense logically because a lot of the concepts are given in the first part that I would have given to you, but we decided to do this one when I'm still fresh, relatively fresh, and so my voice is still at the best since we have to film it. So this first part I will speak like I would have spoken on the expos stage. So I will address to you like if you were also together Kiefer orthopeda, and I'm pretty sure that a lot of you know more about Kiefer orthopedy than some of my colleagues, but still it could be a bit strange when I talk to you about when you treat this patient and so on. It's because this was meant to be for expos. Okay? I apologize if for you some parts maybe will be not so interesting, but I'm pretty sure that for you it's interesting always to get to know what is our daily life and what are the needs of your customers. Okay? So the presentation is vertical control biomechanics. I am Stefano Troiani, and today I will talk to you and I will explain to you how to go from here to here. So basically how to control bite opening and vertical dimension during fixed orthodontic appliance treatment. The first question you could ask me is, why do we want to do it? Only because it looks nice on your final picture, a good intercuspidation? What are the reasons why we want to control the amount of bite opening during treatment? There are different reasons. The reason that we want to avoid posterior interferences is that we want to avoid, for example, hard anterior contacts. If when our patient close their mouth, they hit first with the molars, they will try to find a way to achieve a bite. And there is not a control. They will tend to hit the front teeth very hard, which can give abrasions or anterior crowding. Then other problems, they can have condylar distraction, and another effect of posterior interferences is the doesn't allow to have a proper amount of overbite. The condylar distraction happens because when the patient close, if hits first on the molars, to achieve contact on a maximum amount of teeth possible, the condyle will tend to get distracted. This is a problem, well, according to Jeffrey Okeson, for example, the etiology of temporomandibular problems is a combination of three factors: condylar instability, overloading, and lack of adaptation. This is condylar instability. So it's one risk factor for development on temporomandibular joint problems. Lack of stability can come from lack of adequate overbite because ideal way, normally there are at least 2 contact points between the lower incisor and the upper incisor on each tooth. The upper central incisor, they have 3 contact points so that the 2 lower central incisors can have 2. This is needed in order to have stability, because in this way the anterior teeth, they support each other, upper and lower. What is the problem with this? In order to have all these contacts, especially the 2 central contacts, here and here, you need to go up next to the level of the lingual cingulum of the central incisor. And therefore, you need to have an overbite of at least 3 to 4 millimeters. Having an overbite of 1-2 millimeters is simply too little and will lead to lack of stability over time. Is this confirmed in literature? You can find a lot of studies that tells you that there is a relationship between problems with function and temporomandibular disorders and various kind of symptoms. But if I've got to be honest with you, I could also put you a slide with as many studies that tells you that there is no relation. What is the truth? This is one point that is not very clear according to literature in our field. So we have to rely upon what is also our clinical experience. Now you could tell me, okay, my clinical experience, my personal opinion is that I don't believe there is a relationship between posterior interferences, posterior precontacts, and temporomandibular joint problems. But then you still have another problem. Did it happen to you, and I'm pretty sure it happened to any of you, if you don't want to lie to me, that during treatment you have a patient that doesn't look bad, looks very easy case, you put brackets on, you put wires, and then all of a sudden you have an open bite. Why does this happen? This happens because if the patient has got a distracted position of the condyle due to the fact that there is a posterior interferences, will come to you with a bite that is closed, it's normal. But then, as soon as you start to put arch wires in, the patient will lose the proprioception, meaning that the arch wires will work like if they were a splint. And the condyle will tend to go back in its most anterosuperior position, so the most stable position inside the fossa. And this will mean that will happen the opposite movement of the one that we saw before, and you will get bite opening. So the patient that look to you a very easy class 1 crowding patient, you start to align and all of a sudden you've got a class 2 open bite, maybe even surgical patient. And it's not very nice when it's a surprise for you and for the patient, because you know, if you say something before is science, if you say that afterwards is an excuse. So it's very good to try to foresee this. So this part is why do we care? Why do we want to take care of bite opening during fixed appliance treatment? The next question is how can we do that? Which tools we have to achieve this? If I ask you this, most likely you would answer me, well, we can use elastics. We can use up and down elastics and we can close the bite. Can we do that? This is one patient one of my patients that had this kind of bite opening during treatment, and then I decided to use elastics. So I use a little bit of professional tricks, cutting the arch wire, using vertical elastics, controlling the torque of the upper molars, and the bite gets closed, you can see. And if I stopped here, I could say, well done, but is the whole story. This is the end of treatment. You can say it's not perfect, but it's acceptable. But is this the end? What if I show you this and you start to see something coming up? What if I show you this and you can see that there is a relapse? Why there is a relapse? Because anytime you use vertical elastics, you compound two different effects. You've got an orthodontic relapse, meaning that the teeth that you tend to extrude with elastic will tend to reintrude, and then you've got condylar relapse, because when you use vertical elastics, you apply a vertical force, and if you have a posterior fulcrum, you will tend to distract the condyle that will tend then to go back to its position. So you will have relapse coming from two different sources, and this is why you should not do this. This is just to convince you. But so, if this is not the way, if vertical elastics is not the answer, what is the answer? The answer is here. The answer is that you have to take care of posterior precontacts, of posterior interferences that are mostly located at the level of the second molars. And the trick, one of the tricks to solve this is that you should not take impression, so you don't know that this exists, so you don't need to solve it. But once that you start to look for it, you will see that this is a very recurring problem in your patients. One thing that you may surprise you is that this is not so normal to look at. If you look at what American board did, American board analyzed a lot of the cases presented to them, and found out that the vast majority of mistakes that were present in these cases, and these cases are the best cases presented by American colleagues, were at the level of second molars. This is because we don't look at them. And if you start to look at them, you will see a lot of problems, and you may be able to solve them. So which are these problems? We start with the lower molars. In the lower molars, the typical problem is that you may have over-erupted lower second molars. Normally, they are over-erupted because there is a delay in eruption of the upper second molars, and so in a patient that has got, for example, a distal occlusion, you will have the lower second molars will be free to over-erupt, so they will be above the occlusal plane of the other teeth of the lower arch. You have different ways to address this problem: free anchorage, bite blocks, mini screws, or use light forces. Before going into that, I have to scare you a little bit and show you this. This is one of the most important articles written in the history of orthodontics. It was written in 1974 by Dr. Barston and Koenig. The problem is that Dr. Koenig was an engineer, so it's written in engineer language, which is basically not understandable for normal human beings. But if you really decide to spend 2 or 3 months of your life in reading this article and trying to see what it says, you will see that it actually says things that makes pretty much sense. It says that when you are in this situation, and when you've got a vertical malalignment of 2 teeth, and you want to achieve this, you would like to intrude the tooth that is more extruded, and you would like to extrude the tooth that is more intruded. You would like to level them. And how do you think you achieve this? Well, what you have here is what they call a geometry 1, which means that if you insert a wire, if you put a wire through the slots of the 2 brackets, you will tend to have 2 angles that are equal and on the same side. This will give you an intrusive force and an extrusive force. The problem is that this system here, from a physical point of view, is not in equilibrium, because you've got an intrusive force and an extrusive force. These 2 forces together is what is called a couple of forces. A couple of forces gives something that is called a moment. And a moment needs to be counteracted by equal and opposite moments, because the total amount of force and moments in a system must be 0. It's the third principle of Newton. So what you have in reality, you don't have only these 2 forces, but you have 2 moments also acting on these teeth. Now you can tell me, this is all jolly good, but why do we care about this? You do care, because if you decide to insert a wire in these 2 teeth, you will not get what you may think, that is an intrusion of the more extruded tooth and an extrusion of the more intruded tooth. You will get something else. You will get this kind of movement, because it will be a combined movement that will be expressing not only a vertical force, but also a moment, and a moment express a rotation. This is interesting for you, because if you have such a situation that is an over-erupted second molar, if you just insert an arch wire here, what will happen is that if you get your 2 elements, you will tend to get an extrusive force on the first molar, which will be expressed very much, because extrusive force, they immediately work. An intrusive force on the second molar, which will work much less, because intrusive force take longer to express than extrusive force. But then you will have also 2 moments for which you will tend to get this. And you will have a pre-contact on the distal cusp of the lower second molar. So, in a situation like this, if your patient just get an arch wire inserted, you will get bite opening. In some cases, this can be beneficial if you've got a patient with a deep bite, but in many cases, you don't want this to happen. So, different ways to solve it. First way, free anchorage. For this case, I will show you the case